Good morning, everyone. Let's go ahead and get started here. Welcome to Grand Rounds. It's our pleasure to have Dr. Michael Schwartz with us today from Endocrinology. Dr. Schwartz did his medical school training at Rush Medical College and then medicine residency and endocrine fellowship at the University of Washington. Joined the faculty here where he's now a professor as well as the section head for clinical nutrition. For nearly 10 years, he directed the UW Medicine, Diabetes, and Obesity Center of Excellence and is now the director of the UW Diabetes Institute. He's earned numerous awards and accolades over his career, including holding the Robert H. Williams Endowed Chair in Diabetes Research. Nationally, he's been active on panels and review groups at the NIH. He has over 160 peer-reviewed journal articles, spoken in many national and international forums about his work. His research focuses on the neuroendocrine control of glucose metabolism, as well as the CNS mechanisms involved in obesity and insulin resistance. He's going to talk to us today about brain control of glucose homeostasis and the future of diabetes treatment. Please help me welcome Dr. Schwartz.
Well, it's a pleasure to be here, and I'd like to thank you for the invitation and the opportunity to share what we do mostly over at South Lake Union with a primarily clinical audience. And I'm also a clinician, but most of the work that we do is basic science. But I'm still a believer in the idea that basic science can yield important insights into common diseases. And so I hope I'll convince you that that's true with the work that we're doing as well. So I'm not going to spend a lot of time talking about the disease of type 2 diabetes because I assume that you're all very familiar with it. I will point out that the prevalence worldwide is increasing rapidly, not just in developed countries anymore, but really all around the world. And when you combine that with the fact that most patients still fail to achieve glycemic targets, which puts them at risk for complications, this is why type 2 diabetes is now among not only the most common, but also the most costly diseases worldwide. As you know, therapy for diabetes, type 2 diabetes is what I'm going to focus on today, is mostly insulin-based. There are a series of drugs that enhance insulin secretion, or you can give insulin itself. There are insulin sensitizer drugs, and then there are other types of drugs. Most prominent, I guess, being the newer drugs that induce a renal glucose leak as a way of lowering blood sugar. But what they share in common is that their goal is you take a medication pretty much every day with the hope of lowering blood sugar for that day or part of that day. In other words, achieve short-term control of disease manifestations. Now, it is possible to achieve sustained diabetes remission with certain bariatric surgical procedures like Roux-en-Y gastric bypass or vertical sleeve gastrectomy, but no medical therapy has yet been shown to be able to do this. So let me talk a little bit about the basic understanding of glucose homeostasis that you all learned in medical school, just to set the stage. So we know that nutrients come in through the GI tract. They stimulate insulin secretion from the pancreas. That nutrient stimulation can be augmented by incretin peptides that are released from the GI tract. Insulin lowers the blood sugar both by promoting glucose uptake in tissues like skeletal muscle, but also by inhibiting glucose production primarily by the liver, which is of course where your glucose comes from in your bloodstream when you're not eating. And we know that in type 2 diabetes there are a number of defects in the system. For one thing, you become more insulin resistant, so the ability of insulin to promote glucose uptake and inhibit glucose production in the liver is diminished. And in order to deal with that, you need to make more insulin. And in type 2 diabetes, what happens is you don't make enough insulin, and so you have a combination of insulin resistance and progressive islet failure that results in sustained hyperglycemia. But it's really, so that's just what I said here, but it's really beyond this for reasons that I learned during my fellowship training under Dan Port, who's shown here. This was a picture of him when I was training with him in about the early 1980s or the mid 80s. And this is what he looks like now. And I had a very pleasant week in La Jolla at a couple of meetings last week, which is where he lives, and we had a chance to visit quite a bit, which I really enjoyed. But one of the points that I learned from him during my training is that type 2 diabetes pathogenesis also involves an increase in the defended level of blood sugar. So if any of you checks your blood sugar every morning when you get up before you've had anything to eat, it's going to be fairly constant from one day to the next. It might be 88, 90, 92, but it's not going to be 85, 110. It doesn't really bounce around that much because it's regulated. And if you look at a patient with type 2 diabetes, it's the same thing. Their blood sugar is high, it's out of the normal range, but it's still being regulated. And so in a way, it's similar to what occurs with blood pressure and hypertension. It's not that there's no regulation, it's that it's being regulated at a higher than normal level. And it's the same with body fat mass in obesity. Obesity is a condition associated with the biological defense of an elevated level of body fat mass. So if we go back to this model, does this model really have a way of explaining the defense of elevated levels of blood sugar in type 2 diabetes? And I'm going to try to work through my thinking that it doesn't really. And one thing that stands out, which again I learned from Dan Port during my training with him, is that this idea of let's not talk about the diabetic individual, let's talk about the normal individual who becomes obese and insulin resistant, and yet their fasting blood sugar doesn't change at all, which is not uncommon. In fact, the vast majority of obese people who are insulin resistant don't get diabetes. So they can compensate, right? So you make more insulin, beta cell function increases normally in response to insulin resistance. Well, how does that occur? It's not because there's more glucose, because I just said the glucose level is the same. So there is an alternative mechanism that links insulin secretion to insulin sensitivity. And it follows, therefore, that since type 2 diabetes is a condition where beta cell function does not adapt appropriately for insulin resistance, that there's a defect in this coupling mechanism. So that is how I think we should be thinking about type 2 diabetes, rather than just focusing on the islet or on the insulin resistance. So let me talk a little bit about the coupling between insulin secretion and insulin sensitivity, because a lot of that work was actually done here in Seattle, again, early in my career, not by me, but by Steve Kahn, who many of you know, in collaboration with Rich Bergman, who is now at Cedars-Sinai down in Los Angeles. And what they determined is that there is a hyperbolic relationship between insulin secretion and insulin sensitivity, and Steve has written at length about this. It's shown here in this sort of diagram where you have insulin release here on the y-axis and insulin sensitivity. And for normal individuals, let's say they start out here, if they become obese or insulin resistant due to pregnancy or some other reason, well, then their insulin sensitivity goes down, but their insulin secretion goes up in proportion, such that the product between insulin secretion and insulin sensitivity is constant. So this is a hyperbolic function, and most normal individuals will fall along such a curve. In fact, recent data was published from a meta-analysis that just looked at different human populations from around the world, looking at the acute insulin response to glucose, which is a measure of insulin sensitivity, and the insulin sensitivity index, which of course is a measure of insulin sensitivity, insulin secretion, insulin sensitivity. This is generated from a frequently sampled intravenous glucose tolerance test, which I'm going to show you in a moment. When you use what's called the minimal model analysis of those data, you can deconvolute the data to get a measure of insulin sensitivity during the glucose tolerance test. And that was what was worked out by Rich Bergman, who I just showed you. But the point is, in a large, virtually thousands of humans have now been studied with this methodology, and this relationship seems to hold up. But the first clinical data was generated by Steve Kahn at the VA in normal subjects, and the relationship is shown here, okay? And the product between them, which is represented by this hyperbolic function, is called the disposition index, which basically what that means is this is the net amount of glucose clearance from the bloodstream that can be attributed to insulin. So it's the product of insulin secretion, insulin sensitivity. It's the net insulin effect. Now, the net insulin effect in humans is an important determinant of glucose tolerance. So in other words, where you sit on, whether you're on this curve or some other curve, is going to influence what kind of glucose tolerance you have. And data from that to support that contention was published in a subsequent paper by Steve Kahn's group, by Christina Utschneider, who's also at the VA. So what we're looking at here are quartiles of glucose tolerance. So Kg is the rate constant for clearance of glucose during a glucose tolerance test. And these are the folks in purple have the best glucose tolerance, and these are the folks in white that have the worst glucose tolerance. And the question is, what does that curve look like as you go from good glucose tolerance to poor glucose tolerance? And here's the data. So these are the people with the best glucose tolerance. This is the next quartile. This is the next quartile. And this is the next quartile. So if you take away the individual data points, it basically looks like this. And as you go from here to here, you're losing, your glucose tolerance is becoming impaired and you're progressing towards type 2 diabetes. And that can be shown schematically like this. So as you go from normal glucose tolerance to impaired glucose tolerance to type 2 diabetes, this hyperbolic function that characterizes the relationship between insulin secretion and insulin sensitivity is basically falling down to the left. Now, despite this all being worked out 20 years or so ago, the mechanism that links insulin secretion and insulin sensitivity is still not known. And that's really important because of a defect in that mechanism is contributing to the defense of elevated blood sugar in type 2 diabetes. Well, if you don't know what the mechanism is, then you're not really going to understand what the defect is either. So that's what I'm going to talk about. So what I just said, insight into the mechanism linking insulin secretion and insulin sensitivity is crucial for an improved understanding of type 2 diabetes pathogenesis. And of course, since I'm the one giving a talk, I'm going to ask this question: does the brain play a role? So the data I'm going to show you, actually all the data I'm going to show you today is from our lab is unpublished. So it's, it's the latest stuff that we're doing. Now, our approach to this question was informed, though, by work that we did not do that was in the literature from many years ago, and it has to do with the effect of cold exposure on glucose tolerance and insulin secretion. So there's a little bit of a busy slide, but it's a glucose tolerance test in animals, rats, that were either housed in a warm environment or a cold environment, and they were either fed or fasted. So basically, if you look at the circles versus the triangles, you're looking at warm versus cold. And if we just look at the open ones, for simplicity, this is what it looks like in a warm environment, this is what it looks like in a cold environment. And the point is that if anything, glucose tolerance is better when you're cold than when you're warm, which is not that surprising because when you're cold, you have to use a lot of glucose to generate heat. But the surprising thing about it is what happens if you look at insulin. So here's the insulin response in warm, and here's the insulin response during cold. So the thing is, you're maintaining glucose tolerance that is at least as good as normal when you're cold, despite secreting half as much insulin. Well, how can that be? It must be that insulin sensitivity increased, right? I mean, how else could it happen? But no one had ever really looked at that or looked at the relationship. And so we asked the question, does a compensatory increase of insulin sensitivity explain why, despite reduced insulin secretion, glucose tolerance is preserved during cold exposure? If so, is this adaptive response also mediated centrally? Now, why would we think that? Well, because virtually all of the other adaptations to cold exposure are mediated by the brain, especially the ones that have to do with heat production. So if these adaptive changes in glucose metabolism are related to adaptive changes in heat production, it seemed logical to us that the brain must be involved. So that was the path that we decided to take to interrogate the role of the brain in the mechanisms that link insulin secretion to insulin sensitivity. And the work that I'm going to share with you now was generated by Greg Morton, who is an associate professor in our division and a kind of a partner with me in the lab. We do pretty much everything together. And Ken Muta, who is a first-year postdoc in the lab who's been working on this project. And what we did was we took rats and we began by simply studying them with the frequently sampled intravenous glucose tolerance test, both in a warm environment and in a cold environment. So here's the glucose tolerance data. And in the paradigm that we worked out, which is 4 degrees centigrade for 24 hours, there was no real change of glucose tolerance at all. It's amazingly similar, actually, given how different the metabolic needs of the animal are when they're in warm versus cold. And by the way, 4 degrees centigrade, that's about 38 or 39 degrees. So if you picture a rat living in Seattle, which there are plenty, you know, about a third of the year at nighttime, it's going to get down to that temperature. So this is actually a lot more physiological for a rat than being in a cage at a constant temperature, which is how they're usually studied. Okay, so how do they maintain normal glucose tolerance despite these dramatically different thermal conditions? Well, as was shown previously, there's a dramatic decrease of insulin secretion. So how can that occur and still have normal glucose tolerance? Well, you would expect, as I said, that insulin sensitivity would have increased. So here's the insulin secretion data, the acute insulin response to glucose. I've just shown you that it's reduced. Here's the insulin sensitivity measured from the frequently sampled intravenous glucose tolerance test, which is increased in a compensatory manner, such that the disposition index, which is the net insulin effect, is not significantly different. And this SG term, which I'm not really going to talk about today, is the insulin-independent component of glucose tolerance. And that also is not affected by cold exposure. So, in other words, there is a change in the relationship between insulin secretion and insulin sensitivity, but it's done in a highly coordinated way so that the net insulin effect and glucose tolerance remain exactly the same. In other words, we can envision this as the animal starts out here in the warm. They get put in the cold, their insulin sensitivity increases, but their insulin secretion decreases, and they come down here. So the next question we asked is, well, how quickly are these changes occurring? So to address that, we simply took rats that were down here in the cold, and then we brought them back into a warm environment for just 4 hours. So normally when we think about individuals moving up and down this curve, we're talking about becoming obese or going through pregnancy or going through adolescence, things that take months to occur. We don't usually think about them moving around on this curve within a matter of hours. But then again, we're not normally studying animals under these sorts of physiological challenges. And it makes sense that if you need to change the system quickly, you do. So how long are these sustained? So here's the data. And you can see that once the animals are returned to a warm environment, the effect of previous cold exposure is completely gone. Glucose tolerance, again, is exactly the same, but insulin secretion has returned to baseline. Now, of course, for that to occur, they must have become less insulin sensitive than they were. And that's exactly what happens. The former increase of insulin sensitivity is now gone. And everything just returns completely to normal within 4 hours. In other words, they went down here during the cold, they came back up here within 4 hours. So cold-induced reciprocal changes of insulin secretion and insulin sensitivity are short-lived. And now we get to this question, do they involve the brain? And specifically, are they mediated via the sympathetic nervous system? Because it's well documented that the ability to mount a thermogenic response to cold exposure is critically dependent on sympathetic nervous system outflow. So if these changes of insulin secretion and insulin sensitivity are part of that system, they should be dependent on sympathetic outflow as well. And I want to preface this by saying that people, as I mentioned earlier, have tried to study the mechanism linking the relationship between insulin secretion and insulin sensitivity for decades. And there has never been any convincing demonstration of a mechanism that can do what we're talking about. So what we did, and this was work done primarily by Ken, with a lot of help from Miles Matson in the lab, is to look at the effect of intravenous phentolamine. And as you know, phentolamine is an alpha-adrenergic receptor blocker. And we know from previous work that sympathetic stimulation of the islet inhibits insulin secretion through a mechanism that involves alpha receptors and is blocked by phentolamine. So we chose phentolamine to see if you can reverse the metabolic adaptation to cold exposure by blocking alpha-adrenergic receptors. So now we have cold-exposed animals that either received intravenous vehicle or intravenous phentolamine for 30 minutes before the frequently sampled IBGTT. So now we're looking at things that are happening in a very rapid time frame, just 30 minutes. So you can see that phentolamine did not really affect insulin sensitivity during this, in these cold exposed animals. So throughout all of this, glucose tolerance. Throughout all of this, glucose tolerance is remarkably stable. But what it did do was block the reduction of insulin secretion. So we remember cold exposure reduced insulin secretion, and very rapidly this effect was reversed by phentolamine. Now, if they're making more insulin, but their glucose tolerance is not different, that must mean that their insulin sensitivity is lower. And that's what we found. So basically, what we're saying is if you block sympathetic tone through alpha-adrenergic receptors systemically, within 30 minutes, you can take an animal who has achieved this adaptation to cold and get them to come back up here. So these data lead us to the conclusion that the potent, rapid, and highly coordinated changes of insulin secretion and insulin sensitivity elicited by cold exposure are dependent on sympathetic nervous system outflow. This observation points to a fundamental role for the brain in glucose homeostasis that had not previously been appreciated. And it leads to fundamental questions that I've alluded to previously. Does a central defect contribute to the defense of elevated blood sugar in patients with type 2 diabetes? And I would point out, in defense of this idea, remember that this phenomenon of defense of elevated blood sugar is similar to the defense of elevated blood pressure in patients with hypertension and defense of elevated body fat mass in individuals with obesity. And in fact, those three disorders, defense of elevated blood sugar, defense of elevated blood pressure, defense of elevated body fat mass, all cluster together as part of the metabolic syndrome. And we know that the brain is involved in the pathogenesis of essential hypertension and in the pathogenesis of obesity. So I would argue that these are all part of a cluster of defects in which the homeostatic defense of important physiological variables gets pushed upwards. So the value of the variable that is being defended, it becomes elevated. Now, if type 2 diabetes involves dysfunction of a central regulatory system, interventions that address the underlying defect, in theory, should have the potential to restore normal glucose homeostasis rather than just lower blood sugar levels. So remember, if you think about the drugs that you take for diabetes, if we think about insulin as a sort of prototype, when you give insulin, the insulin doesn't care what your blood sugar is. It's just lowering your blood sugar. So it's not normalizing anything. It's just taking a high blood sugar and lowering it. But if you have a normal blood sugar and you take insulin, it's still going to lower it, and you're going to get hypoglycemia. So that's not reversing an underlying pathology. It's simply treating a manifestation. But if you can get at what the problem is, the underlying problem, and treat that, then you may be able to normalize blood sugar in a sustained way without the risk of hypoglycemia. And that, of course, has been achieved with bariatric surgery. And these are data from a paper that was published by Schauer and colleagues in the New England Journal of Medicine a few years ago, a very famous paper that compared medical treatment of type 2 diabetes with surgical treatment, bariatric surgery, either Roux-en-Y gastric bypass or sleeve gastrectomy. And this is just the fasting blood sugar, the change in fasting blood sugar. You know, medical treatment might give you a 20 milligram per deciliter decrease on the average, whereas you can get down to 80 with bariatric surgery. But I would also point out that for the most part, and I think David Cummings, who's here today, might disagree with me on this, these sustained reductions of blood sugar are generally speaking associated with pretty substantial decreases in body fat content. Now, there is an argument to be made for the fact that bariatric surgery can induce weight loss independent glucose lowering. But even if that's true, it's typically associated with weight loss anyway. So I would submit that truly weight loss independent diabetes remission has yet to be demonstrated, although there may be some data that would counter that argument. It's not a major point for me anyway. So now I'm going to change directions for the second half of the talk and talk about the fibroblast growth factor family of peptides in relation to targeting the brain to treat diabetes. And this is a large family of FGF peptides shown here, and I'm not going to go into it at all except to say that some of these are hormonal. This is the hormonal family. And some of these have been implicated as potential targets for, or strategies for treating diabetes. And in particular, FGF19, FGF21, and more recently, FGF1, which was the first one to be discovered, have been shown, when administered at pharmacological doses, to elicit glucose lowering, but typically without hypoglycemia. Now, in the case of FGF19 and FGF21, when you give them systemically, the effect is fairly transient, less than 1 day. But with FGF1, when you give it, you get a more durable effect. It lasts closer to 2 days. And it appears that the brain is a target for at least some of these peptides. And here's some of the data I'm going to just summarize with FGF19, work from Randy Seeley's lab showing that if you put FGF19 in the brain, this improves glucose tolerance in rats. Similar findings from Streams and Chua's lab, and with identifying a potential neural target to mediate the effect. And Greg Morton and I published a paper a couple of years ago showing that FGF19 action in the brain of mice induces potent and rapid glucose lowering in obese diabetic mice through a mechanism that seems to involve an insulin-independent glucose lowering phenomenon, which the brain had not previously been shown to have that capability. But I want to turn our attention to this paper, which showed that if you give FGF1 systemically, it has insulin sensitizing effects and therefore has an anti-diabetic effect. Now, one of the mouse models that is most widely used for studying type 2 diabetes and its treatment is the OB mouse, which has obesity and stable hyperglycemia. It kind of looks like type 2 diabetes, but the mechanism underlying it is that they don't make leptin. So they're leptin deficient mice. And in this paper, it was shown that if you give FGF1 at this dose subcutaneously, 30 micrograms, which this shows you the dose response curve. So this, you have to give a fairly high dose out here to get this kind of glucose lowering. And what you see in these mice is a single injection will get you from a blood sugar over 300 down to nearly normal, basically normal blood sugar, and then it comes back up again. It lasts almost 2 days, so it was pretty striking. So what we hypothesized is that the anti-diabetic effect of FGF1 involves a central mechanism, and consequently both the duration and potency of FGF1-mediated glucose lowering will be increased by ICV, or intracerebroventricular administration. And the data I'm going to show you were generated primarily by Jared Scarlett, who is basically a fellow in the lab. He's also an acting instructor at Seattle Children's Hospital in pediatric gastroenterology, and Jennifer Rojas, who is a postdoc who's just completing her fellowship now and is taking a job at Novo Nordisk that will begin in the summer. And the data I'm going to share with you are unpublished, but they are accepted for publication. The paper comes out in Nature Medicine within a month. And so here's what we did. We gave either vehicle or FGF1 as an ICV injection to OB mice at a dose of 3 micrograms. Now remember, the dose that works systemically is 30 micrograms, so this is 1/10 of that dose. And then we measured their fasting blood sugar 6 hours after the injection, and then we did an intraperitoneal glucose tolerance test to look at glucose tolerance. And we found that within 6 hours of the injection, and the animals were not allowed to eat during this period, so this change was not due to changes of food intake or body weight. What we found was that there is a substantial decrease of basal blood sugar, fasting blood sugar, although glucose tolerance wasn't really affected. Now, the first thing we wanted to do is make sure that this effect wasn't due to leakage of the FGF1 peptide from the brain to the periphery. And there's a simple way to test for that. That is, just give the same dose as a systemic injection rather than ICV. And as expected, this dose of 3 micrograms when given systemically is too low to have any effect. So glucose lowering by ICV FGF1 is not mediated by leakage into the periphery. So then the question was, well, how long does it last? Does it last longer than other things that we have done to treat type 2 diabetes? And so we took the same animals that had had this injection where we looked at 6 hours, and we just brought them back in a week later and looked a week later. So there is nothing you can do really to give you a week-long normalization of blood sugar. There's really no precedent, whether you're using the brain or something else, unless you're talking about a dramatic caloric restriction or something like that. But what we found in these mice was that the glucose lowering effect had actually increased over the course of the week, quite a bit. So now they had blood sugars that are completely normal. Glucose tolerance, again, was maybe a little bit better than it is here in the vehicle group, but the main effect was a dramatic decrease in basal glucose levels. So we just decided to monitor them over time. Here's the data at 2 weeks. They're still basically in the normal range. So how long does it last? So I'll just show you the basal glucose values. We actually did a glucose tolerance test at every one of these time points, but we'll just show you the basal values over time. And so here's the baseline. Here's the date of ICV injection. And here we are out at 5 weeks. So the effect is still there at 5 weeks. It's still there at 10 weeks. And we went all the way out to 20 weeks, or 18 weeks. at which point we decided there was no reason to continue the experiment because we were just getting the same data week after week. So we terminated the experiment and concluded that glucose lowering induced by a single ICV injection of FGF1 is seemingly permanent in OB mice. In other words, ICV FGF1 induces sustained diabetes remission in these animals. Now, we were so surprised by this observation that we immediately decided that we needed to try to replicate it. And we replicated it not only with the murine FGF1, which we had used before, but the human FGF1, the human recombinant peptide, in a separate group of animals. And then there was also an ICV vehicle group as well. And what you see here in the blue and red is that although it took a day for the human FGF1 effect to kick in, they actually had no acute glucose lowering at all, but within a day they had come down to exactly the same normalization of basal blood sugar. And again, we monitored them out to 4 weeks and discontinued the experiment. So the finding is reproducible. In fact, we've seen it so many times now that that's really not a question for us. But let's get back to the issue of food intake and body weight. I mentioned that you don't really see this type of thing without having a decrease of food intake and body fat mass, and that is certainly associated with bariatric surgical procedures. So what about with FGF1? Now, it turns out that FGF1 does reduce food intake and body weight, but the effect occurs rapidly and only lasts for a day or two. So that if you look weekly, these are the same data I showed you at the beginning, and there was a small decrease of intake in the first week because of that acute reduction of food intake on the first day. But it normalized such that over the course of 18 weeks, there really was no difference of food intake or body weight or fat mass, which was measured here at week 4. So although ICV-FGF1 does induce transient anorexia and weight loss, sustained normalization of fasting blood sugar was not associated with reduced body weight or fat mass. And just to drive the point home, we did a pair feeding experiment, which I won't show you the data, simply to show that if OB mice are only allowed to eat the amount of food consumed by animals that get ICV-FGF1, they do not have diabetes remission. So the effect of ICV-FGF1 to induce diabetes remission is not due to reduced food intake or body fat stores. So what about other models? I mean, this is an OB mouse, it's leptin deficient, it's not necessarily that relevant to human type 2 diabetes. Well, the first mouse we studied was another model that's quite commonly used in the type 2 diabetes field. It's the DB mouse. We saw a similar effect, again, without changes of body weight, but this mouse is also a monogenic obesity syndrome, in this case due to leptin receptor mutation. So it's, again, you could argue not necessarily relevant to humans. What about just wild type mice that are made diabetic and obese? So you can do that, but it's actually hard to make wild type mice diabetic with diet alone. You can make them obese, but you have to do something else to make them diabetic. And in this case, we gave them a low dose of streptozotocin, which is a pancreatic beta cell toxin, so that they do get their blood sugar up into the range of 200 or higher with this obesity, diet-induced obesity with low-dose streptozotocin. And we see, again, remission of this hyperglycemia that is sustained by a single ICV injection of FGF1 that is not attributable to changes of body weight. What about a different species than the mouse? What about rats? Well, this is the Zucker diabetic fatty rat, which is a model of type 2 diabetes, and you see, again, a single ICV injection has the same effect, sustained diabetes remission. It begins to fall off here after about a month, and we actually know that they relapse if you carry this out to 60 days, and that relapse appears to be associated with progressive islet failure in this animal model. But the point I want to make next has to do with something that's very important about these observations, which is that although we see diabetes remission consistently, we virtually never see hypoglycemia. Even in normal wild-type mice, which is shown here, if you give them the same dose, you see reduced food intake and body weight that is transient, but there's only a slight downward blip of blood sugar, and we never see hypoglycemia. So there aren't really very many treatments, there's really none, where you do it and you normalize the blood sugar without risk of hypoglycemia. So that's something kind of fundamentally different. Now, what is the peripheral mechanism that mediates this effect? Well, if you go back to this paper that I mentioned, where they gave FGF1 systemically, they argued that it works primarily by increasing insulin sensitivity, and that the effect was due to activation of FGF receptors in fat tissue. Well, I think we can say with some confidence that the effect that we're seeing is not due to activating FGF receptors in adipose tissue, because we've already shown that the dose we use when you put it in the brain doesn't work if you give it systemically. So it can't really be mediated by adipose tissue. So maybe there's a different mechanism, but does it still involve an increase of insulin sensitivity? So our data suggests that it doesn't. And here's some of the data. This is an insulin tolerance test in OB mice treated with either ICV, FGF1, or vehicle 3 weeks following the injection. So these are the vehicle-treated animals that have the stable hyperglycemia. You give them insulin, and you get this modest lowering of blood sugar because the animals are insulin resistant. Well, if you do it in animals that have FGF1-induced diabetes remission, they start down here at a lower blood sugar, but the effect of insulin is really basically the same if you subtract out the difference in basal. So this insulin tolerance test data suggests that insulin sensitivity is actually not increased in animals that have diabetes remission induced by FGF1. And we tested that more formally by doing the frequently sampled intravenous glucose tolerance test with help from the laboratory of David Wasserman at Vanderbilt and with minimal model expertise provided by Rich Bergman, who created the minimal model, along with his former trainee, Darko Stefanovsky. So here's the frequently sampled glucose tolerance test data, and it looks like glucose tolerance is improved here with ICV FGF1, but if you adjust for the difference in basal glucose, there actually is no significant difference in glucose tolerance. So really the main effect is a basal glucose effect, not a glucose tolerance effect. And consequently, the determinants of glucose tolerance, insulin secretion, insulin-independent glucose disposal, and insulin sensitivity, although each of them tended to be higher in the group that received FGF1, none of those differences achieved statistical significance. Moreover, plasma levels of glucagon and corticosterone were also not different in the animals that received ICV FGF1. What was different was the rate of clearance of glucose from the bloodstream was increased by about twofold. And that was without any difference in the basal rate of hepatic glucose production in fasted animals, which is, of course, where the glucose in the bloodstream is coming from when you're fasted, is mainly from the liver. Now, there is a caveat to this because these studies were done when the blood sugar was lower in these animals than it is in these animals. So we looked at the relationship between the basal glucose clearance rate and the fasting insulin level. And as expected, the fasting insulin level is related to the basal glucose clearance rate in these animals. And it's related in animals that receive ICV FGF1, but the relationship is different, such that for any given fasting insulin level, the rate of basal glucose clearance is increased. So that led us to ask whether FGF1-induced diabetes remission is dependent on intact basal insulin action. And the approach we took was to determine if wild-type normal mice, where you induce diabetes by systemic administration of an insulin receptor blocker called S961, which was provided to us by Novo Nordisk, do these animals become resistant to FGF1-induced glucose lowering? And the answer to that question is yes. These are normal mice. On days -2 on this scale, they begin receiving a continuous infusion of the insulin receptor blocker that causes hyperglycemia. On day 0, they receive either ICV, FGF1, or vehicle, and there's no difference. So diabetes remission induced by FGF1 action in the brain is dependent on an intact insulin signal. So what are the tissues in which glucose uptake is increased in the basal state? Well, we had a clue from the fact that basal lactate levels were elevated. And in the basal state, when you're fasted, most of the lactate in circulation is coming from glycolysis of glucose in some tissue, and then it undergoes glycolysis to lactate, and the lactate gets released back into the circulation. And if you're not exercising, most of that is occurring in the liver. So we thought maybe the liver was involved in increased glucose uptake. And consistent with that, there was increased glycogen storage in the liver and increased expression of genes that are rate limiting for glucose transport into the liver, including glucokinase, liver pyruvate kinase. The glycogen synthase enzyme seemed to be increased as well. So it looks like there may be an increase of hepatic glucose uptake that accounts for the increase of basal clearance, but we did a completely separate experiment. Again, all of this was done with help from David Wasserman at Vanderbilt, using radio-labeled 2-deoxyglucose, and we found that the rate of glucose uptake or clearance into skeletal muscle was increased by about 2-fold, but not in brain, heart, or brown or white adipose tissue. So now I'm going to come to the end of the talk and ask this question. How does FGF1 action in the brain induce sustained diabetes remission without inducing hypoglycemia? In other words, it's not acting in the brain just to lower blood sugar. It's normalizing something that was not working properly. I don't see how it could be anything other than that you would get the blood sugar to drop into the normal range without hypoglycemia. So our hypothesis, our working hypothesis that we're working on now, is that neurocircuits involved in glucose homeostasis are dysfunctional in type 2 diabetes. This dysfunction contributes to diabetic hyperglycemia, and FGF1 corrects this defect without altering the circuitry of normal animals. So we're just beginning to work in this area, and we have some preliminary data that are very interesting to me, which is if you looked at synaptophysin content in the hypothalamus, the animals, this is OB mice 1 week after a single ICV injection. So these animals are now in remission. Synaptophysin is a marker of synaptic content. So we're basically estimating the total amount of synapses in the hypothalamus. And what we find is that within a week, it's increased by nearly 25%. Now, 25% may not seem like a lot, but if you're talking about the total number of synapses in the hypothalamus, that's actually a lot. So that's got us kind of excited now to go in and look using histochemistry at different hypothalamic areas to figure out where these changes in synaptic content are located, and then we can map the circuit. And we already know what the circuit is that's involved in thermal regulation, so we can work our way backwards to see if there's a convergence between the circuits involved in thermal regulation and the circuits involved in glucose homeostasis. So to summarize, central FGF1 administration induces diabetes remission in rodent models of type 2 diabetes. This effect is not due to changes of food intake or body weight. It's not associated with hypoglycemia, and it involves an apparently novel mechanism of glucose lowering. So if the brain plays a key role to couple insulin secretion, insulin sensitivity, and if a defect in this coupling contributes to the defense of elevated blood sugar levels in type 2, it follows that the brain plays a greater role in both glucose homeostasis and diabetes pathogenesis than was previously thought. And the brain's inherent potential to induce sustained diabetes remission raises new possibilities for the future treatment of this disease. I want to acknowledge 25 years of support from the NIH. And this is our group, photo taken at our Christmas party a few months ago. And I want to single out some folks. I showed you data from Ken Muda, Jennifer Rojas, Jared Scarlett, Zayman Mirzada, who's in town, also contributed work that was published in our FGF1 paper. I didn't have time to show it today. We have a phenomenal research staff. Greg Morton is my sort of partner in crime over at South Lake Union. Rich Bergman and Darko Stefanovsky were responsible for the modeling of our glucose tolerance data. Dave Wasserman did a lot of the sort of high-intensity metabolic phenotyping in our mouse models, and we've been generously supported in the conduct of this work by Novo Nordisk. Thank you very much for your attention.
For the dosing of the, and great talk, by the way, thank you very much. For the dosing of the intramuscular or the sub-Q injection, how was that determined, and did you explore it in even more higher doses to see what effect that could have?
Well, so for the peripheral administration, we do replicate what was in that Nature paper from Evans, that if you give a big enough dose, you do get glucose lowering. And that was really all we wanted to do there. And what we wanted to show was the effect we see when we put it in the brain cannot be explained by an effect in the periphery.
I was wondering if FGF1 is actually measurable in human plasma or cerebral spinal fluid. Is it?
So FGF1 is tightly bound to heparan sulfate proteoglycan, so it doesn't really get out of the extracellular fluid compartment. It's not really present in circulation. It is made in the brain, and there are certain, it's actually important during neural development. The FGF receptor system is crucial to neural development, although there's a lot of redundancy. So there's many FGF peptides that participate. But it is made not only during development, but in adult animals. And we have some interest down the road of interrogating the physiological role of FGF1 and if there's something wrong with it in diabetes, but we haven't done that work yet.
Thank you for a very interesting talk. I'm interested in your ideas about the opposite side and whether central mechanisms might be playing a more important role in hypoglycemic unawareness and whether there's some implications for that by this kind of intervention.
I do think that central mechanisms are responsible for hypoglycemic unawareness. I think that's very likely. We actually, Greg Morton and Tom Meek published a paper just this year where we basically mapped the neurocircuit that is responsible for the response to hypoglycemia in the hypothalamus. And once having identified that circuit, if you inactivate the circuit, it's really just one key population of neurons in the ventromedial nucleus of the hypothalamus. You can now, with experimental tools like optogenetics that are available, you can acutely inactivate neurons that are otherwise normal. And when you do that and then give them hypoglycemia, they don't respond to hypoglycemia at all. And they don't recover from hypoglycemia. So I think as we increase our knowledge of how the brain, there are many sites in which glucose information is funneled into the brain. Many brain areas are glucose sensitive, and there are peripheral sites like the portal vein, which transmits glucose information to the brain. So the emerging picture is that there are multiple sites for providing input to the brain about whether you have a glucose problem or not. But once you have a problem, it has to go through one set of neurons in order to trigger the compensatory response, even though the compensatory response is very elaborate and involves many different components. It's all going through one set of neurons.
Yeah, it's really fascinating process. If I understand it correctly, the influence of the FGF in the brain is mediated by increased glucose in the liver.
We think the liver and the skeletal muscle.
And so you have any speculation on what is the nature of the message?
Yeah, it's an important question. You know, if I had to speculate, it would involve the autonomic nervous system, probably both branches. And there's probably so much redundancy in that system that, you know, if you just denervate the liver or something like that, that may not be enough for the effect to go away. And so the problem is that it's actually challenging to design the right experiment to test that, because most people will say, well, you know, we'll try to cause a sympathetic denervation, or we'll cut the vagus nerve or something like that. But if it's highly redundant in that way, and neither branch is sufficient to explain the whole effect, then you draw the wrong conclusion when the effect doesn't go away.
Wonderful talk, Mike, as always. Two questions if possible. Do you know yet, or do you plan to look at whether FGF1 injection in the brain affects hypothalamic inflammation?
It's a perfectly good question. In fact, there was a paper that just came out yesterday in the Journal of Neuroscience showing that microglia and astrocytes are in the spinal cord are very responsive to FGF1, and FGF1 has been shown to have beneficial effects on the recovery from spinal cord injury. And they're arguing that the effect of FGF1 on the glial cells is what's important in providing improvement in recovery from injury. So you could certainly argue that type 2 diabetes involves some glial, you know, Josh Thaler's work right now is focused on gliosis in the hypothalamus in association with obesity. It could certainly be involved in the disruption of neurocircuits that leads to the defense of elevated body weight, since obesity and type 2 diabetes tend to go together. And it could be that FGF1 is doing something to reverse that, and we just haven't gotten to doing that experiment.
Seems like a natural next thing to do, and it might explain the long-term effects. In the first stuff that you showed on the cold exposure, when you showed that cold exposure allows a lower insulin secretion but preserved glucose tolerance, you reasoned that that implies increased insulin sensitivity. And at the time, I thought, oh no, that's just insulin-independent glucose uptake because they're shivering, which I would expect to increase that. Then you showed that that's not changed. At 4 degrees, do rats not shiver?
Well, they do shiver, but
shouldn't that increase insulin-independent glucose uptake?
when we did the experiment, that's what we expected, but it's not what we saw. And just to anticipate your next question, we've actually gone back now with the phentolamine experiment and done it in a clamp study. And the increase of insulin sensitivity in the cold, when you measure it with a clamp, is reversed by phentolamine administration also. So there is an effect of cold to increase insulin sensitivity that is blocked by phentolamine, whether you use the FSIGT method or the clamp method. So I mean, I don't, you know, I would have expected an increase of insulin-independent glucose lowering, but that's not what it appears to be.
All right, we'll close there. Thank you very much.